A patient presents to the clinic reporting progressive, severe fatigue and persistent shortness of breath. But her behavior in the kitchen points toward a specific diagnosis. She is aggressively crushing and chewing ice. This intense neurological compulsion to chew ice is called pygophagia. It is a highly specific indicator of systemic iron depletion. The patient is Joan, a 28-year-old bank executive. Her medical history reveals a significant historical risk factor, severe menorrhagia. She experiences heavy menstrual bleeding lasting up to 8 days per cycle, requiring pad changes every 1 to 2 hours. To manage her dysmenorrhea, Joan regularly takes ibuprofen. Chronic use of nonsteroidal anti-inflammatory drugs creates a secondary risk for gastrointestinal blood loss via enteropathy. Systemic iron depletion is already manifesting physically. An oral examination shows angular chylitis, painful fissures at the mouth's corners, and atrophic glossitis, leaving the tongue smooth, pale, and devoid of papillae. Finally, her hands reveal early koilonychia, a distinct upward spooning of the fingernails. Iron acts as a vital cofactor for numerous cellular enzymes. Its absence is felt in the epithelial tissues as much as in the blood. These physical abnormalities prove that a severe systemic deficit exists. To treat Joan effectively, we must look past the symptoms and identify the driving mechanical failure. This etiology chart organizes iron deficiency into 3 primary mechanical pathways. First, decreased intake, typically from restrictive diets. Second, decreased absorption, driven by conditions like celiac disease blocking gut transport. Third, chronic blood loss, primarily through gastrointestinal bleeding or heavy menstrual cycles. In adult patients in resource-abundant settings, a strict diagnostic rule applies. You must assume chronic blood loss is the active pathway until proven otherwise. Joan presents with a combined physiological burden. Her extreme menorrhagia, paired with NSAID-induced gastrointestinal bleeding, places her exactly in this high-risk hemorrhagic category. Diagnosing anemia only tells you that a physiological mechanism is currently failing. True medical resolution requires finding the site of the hemorrhage and stopping the leak. This lab ticket and the accompanying blood smear confirm the severity of Joan's condition. Her hemoglobin has dropped to 7.8 grams per deciliter. Her mean corpuscular volume is 68 femtoliters, indicating profound microcytosis. The peripheral blood smear visualizes the result. Her red blood cells are abnormally small and pale, lacking their normal central density. This specific morphology occurs because iron forms the essential nucleus of the iron-porphyrin heme ring. Without adequate iron, her bone marrow cannot synthesize sufficient hemoglobin. Her CBC also shows an elevated platelet count of 480,000. This is a common reactive finding, as her body increases erythropoietin production to stimulate red blood cells, which ends up cross-stimulating platelet precursors. This table comparing Joan's iron studies to standard diagnostic patterns confirms the exact cellular deficit. Her serum ferritin, the protein that stores iron in the body, is sitting at a depleted 8 nanograms per milliliter. A critical clerkship takeaway is that a ferritin level below 30 nanograms per milliliter is the highly specific gold standard diagnostic threshold for iron deficiency. The bone marrow cannot build what it doesn't have.
The circulating anemia we see in the blood is the direct, delayed consequence of an entirely emptied iron storage vault. This balance scale illustrates the exact physiological imbalance that emptied Joan's storage vault. An average diet only yields about 1 to 2 milligrams of absorbed iron per day. Because every milliliter of lost blood contains about 0.5 milligrams of iron, her heavy menses and NSAID-induced bleeding generate a massive continuous output that easily overwhelms her normal dietary intake. As her iron stores vanish, the liver initiates a molecular compensatory response. The liver detects the depletion and suppresses its production of hepcidin, the master iron regulatory hormone. By dropping hepcidin levels, the body prevents the internalization and degradation of ferroportin, the primary iron export protein on cell membranes. Maintaining these ferroportin channels open is an attempt to maximize the flow of iron from macrophages and the gut directly into the bloodstream. Concurrently, a secondary compensatory mechanism activates. The liver upregulates the production of the transport protein transferrin in a bid to capture any circulating iron molecules. This upregulation drives Joan's total iron binding capacity high, while her transferrin saturation plunges to a critically low 5%. Despite a coordinated effort to scavenge iron by manipulating hepcidin and transferrin, the sheer mechanical volume of her blood loss outpaces her biology. This treatment algorithm maps out our medical intervention based on her clinical severity. Because Joan's vital signs show she is hemodynamically stable, we can rule out a red blood cell transfusion. Following the flowchart, the definitive first-line therapy is oral iron supplementation. The specific prescription is oral ferrous sulfate, delivering 65 milligrams of elemental iron per dose. But how we dose that iron matters. An outdated professional misconception is that iron must be prescribed daily to correct a severe deficit. This schedule highlights the modern protocol. Take the medication every other day. Alternate day dosing prevents sharp hepcidin spikes that block subsequent iron absorption. Bypassing these roadblocks ensures iron reaches the bloodstream, instead of remaining in the gut to cause severe gastrointestinal toxicity. This diagram illustrates the biochemical requirements to absorb the pill. Epical DMT1 transporters only accept soluble ferrous, or Fe2+, iron, rejecting the ferric state found in most diets. Co-administering vitamin C lowers stomach pH, chemically reducing iron into the highly absorbable ferrous state. Effective therapeutics require outsmarting enterocyte biochemistry. We dose on alternate days to bypass hepcidin roadblocks, and we add vitamin C to enable the DMT1 transporters. This hematopoietic activation curve maps Joan's recovery timeline. Pagophagia resolves rapidly. By days 7 to 10, a reticulocyte peak confirms bone marrow activation. Hemoglobin demonstrates a measurable rise by week 2, fully normalizing by weeks 6 to 8. However, oral therapy must continue for 3 to 6 months beyond that hemoglobin normalization. Stopping early leaves the marrow ferritin stores empty, guaranteeing a relapse. True clinical resolution demands both the relentless biochemical repletion of marrow stores and a mandatory gynecology referral to stop the underlying hemorrhagic leak. Diagnosing the labs is a science. Treating the whole patient is medicine.